Good afternoon, good morning, and welcome to the ISTH webinar series. I'm Flora Peyvandi, Professor of Medicine at University of Milan. It's a big honor and pleasure moderating today the webinar on gene therapy in hemophilia. With me, we have Professor Vincenzo Mura, Marica Moro, and Cristina Novembrino, who will be discussing the clinical care strategies for gene therapy. Before to start, please remember to scan for your CME information. The objective learning objective of today would be the referring, preparation, and administration of therapies for eligible patients, implementing a personalized approach to hemophilia management based on outcome of gene therapy, resulting factor levels and changing over time. We also discussed the following of patients for short and long term after the dosing and implementation modification to the multidisciplinary care, which we usually are used to have it in hemophilia centers, but how we have to adopt it, this approach for the needs of the gene therapy will be discussed. Let's go to look on what we know about AAV gene therapy in hemophilia. The goal of gene therapy is to compensate for the dysfunctional gene, which is factor 8 in hemophilia A and factor 9 in hemophilia B, for exogenous function to get cure or to make a long-term expression. What are the licensed gene therapies until now? We have one product, Roctavian, available for hemophilia A, which has been approved by FDA and EMA. We have two products for hemophilia B. How is the patient's journey and what need to be considered for a center which is going to start the gene therapy? Clinicians, they need to provide information to the patient. So then they need to be prepared, understanding the pros and cons, safety and efficacy of every single drugs available in gene therapy. Then they have to be able to communicate that information to the patients and trying to propose the best choice for their patient. Inclusion and exclusion criteria and preparation of very complete informed consents is a very crucial point of this type of treatment. Drug preparation with a pharmacist, which is expert, and this pharmacist, they can manage at the time of the dosing and also for all the steps before and after. The day of infusion, we will have chance to discuss about that, is emotionally extremely important for your patients and need to be focused and managed very well for the safety for your patients. And of course, post-infusion monitoring, short-term and long-term. What are the points that in education of your patient are important, and what are the information that your patients should need to know? Drug mechanism of action, however is complicated, you need to explain it in a very transparent and easy way, including all pros and cons to your patient. Eligibility criteria, risk, benefit, adverse event, durability of the expression, and how long time that expression could remain, the transgene expression level, maximum and minimum during this time of expression, what is the risk of integration and what exactly that means, immunogenicity, genotoxicity, or long-term follow-up, how would be done, what is the frequency, and supporting all over your patient for the decision-making autonomy is a very important and extremely important point that you have to consider. Who are the patients that could be candidate at this stage? They should be adults, because pediatric patients at this stage, our knowledge is bringing that there would be a dilution of the transgene expression due to the increased size of the liver, and that amount of expression would not be enough in the future. For hemophilia A, patients less than 1% and for hemophilia B, less than 2% could be included. All of them, they should have at least 150 exposure days previously to factor 8 or factor 9. And they have to be on prophylaxis or having the bleeding episode that could justify in the last 12 months that they are good candidate for having this type of treatment. No inhibitor to factor 8 and 9 should be present, and you want to make sure that your patient accepted the concept of not using alcohol, or really minimum is better absence in the 6 months at least to 1 year after the dosing. Acceptance of using condom to avoid pregnancy and the passage of the viral vector to fetus is important, and you need to explain it very well. Exclusion criteria is detectable immunity against AAV capsid for hemophilia A. However, this is not always true for hemophilia B and only very high titer. And then all other conditions in terms of health of your liver of your patient, which will be explained by Professor Mura, and hypersensitivity or history of allergic reaction to factor 8 and 9 replacement therapy is a criteria of exclusion, and also risk of thromboembolic events, because the transgenic expression sometimes could be associated with a high level of expression. Participation in a gene transfer within 1 year before the dosing is actually one of the criteria of exclusion. What are the contraindications? The contraindication, again, will be explained very well, but hepatic impairment or malignancy or any kind of serious psychiatric disorder like personality disorder or dissociative disorder might affect the correct understanding of information that is received regarding the gene therapy for your patient, and it could be harmful for your patient, should be excluded the presence of this patient for accepting or dosing by gene therapy. Right now, the ISTH SSC working group on gene therapy and Dr. Kutika is trying to standardize the psychological evaluation and make sure that we are all using the similar strategy. The multidisciplinary team is the key word for the success of the gene therapy. We all are used in Hemophilia Center to have a multidisciplinary team. However, this model is really the most sophisticated because you do need to make sure that you have hepatologists, you have a nurse, psychologists, and all the people are collaborating together to make sure that the information have been passed to your patient and the communication has been very transparent, and in any case, after the before and after the dosing, the need of the patient should be satisfied. So all over to what I explained, this slide or cartoon which has been published is clearly reporting that there is an initial step of information chatting between your patient and yourself, and consultation with the hematologist, and preparation of the informed consent, and involvement of hepatologists and psychologists, and then the presence of the negative anti-AAV test for hemophilia A, and eligibility and a selection criteria that we have discussed. And then finally, we're going to get to the day of dosing and administration of the gene therapy, where the role of your pharmacist and the nurse and anesthesiologist is important to make sure the safety of your patient. And after dosing, your patient now has to accept the importance of evaluation of the short-time follow-up, and also the long-time follow-up is important. So during the drug preparation, as I said, you need to work with your pharmacist and to make sure that everything is placed. We have actually the role of nurses, which is extremely important. Marica is trying to explain you the administration and the role of the nurse at the time of the administration, and also the monitoring of post-infusion and how the role of your nurse for the evaluation of any kind of side effect and the discharge of the materials and also the data sharing between the hub and spoke. If your patient is from hub center, as it happened to us, so is everything easy, is in our place, and the patient is just, he knows us. But if the patient is coming from a spoke, there is also the role of a physician who is from the spoke center. So the collaboration between the hub and spoke is extremely important. Behavior indications. And also, finally, but most important point is your lab. Cristina will explain why the lab role is important during the gene therapy and how you have to be prepared for that. And you remember there was a question on how we have to behave for the prophylaxis, when it has to be discontinued. I think that needs the stratification in the future. But what we do in Milan, we want to make sure that the level of transgene expression is at least 5% to 10%. And if it's a emicizumab treatment, again, you need to have a good lab that is evaluating until when there is the drug in the circulation and when the expression of factor 8 and 9 is starting. So all these points are very, very important. And about the monitoring of your patient post-infusion is a bit different from hemophilia A and B. This is a table that Italians, we have prepared at the national level, very much close to what was the information coming with the Roctavian. But you can see that in the first 6 months, the evaluation of liver health and factor assays is almost monthly, and the liver imaging is important if anything is showing the level of ALT and ASTs increase, but we need to have the basic ultrasounds, and every 6 months we are going to evaluate it. Joint assessment is usually annual, but at the beginning, we need to understand what are all the scores, and psychological evaluation at the beginning and then on demand. Similar aspect for hemophilia B, with the difference that for hemophilia B, the most concentration is at the first 3 months with a weekly evaluation of ALT, AST, and factor activity. What need to be recommended to your patient? As a contraception for 6 months, patient and their parent should prevent or postpone the pregnancy. There should be a double barrier contraception, no sperm donation, blood or organ or tissue or cell donation. As I said, the alcohol usage should be minimum or absent completely for almost a year. With this one, I want to thank you for your attention, and I will leave it to Professor Mura to present all the safety regarding the liver health during the gene therapy.
Thank you, Flora, for giving me the floor. Thank you, ISTH, for allowing us to bring our hepatological experience accumulated in Milan. The first point is why we are going to talk about the liver in gene therapy. This is because gene therapy can have a potential impact on liver health in terms of short-term adverse effects, among them the elevation of liver enzymes, particularly ILT, with the consequent risk of loss of the transgene expression, and hypothetically also for long-term adverse effects that could include the risk of hepatocellular cancer due to integration and the risk of chronic liver damage. So in this picture, the role of the hepatologist is active in terms of selection of candidates, because we need a tight hepatological evaluation based on liver enzyme tests, but also on liver ultrasound and fibroscan to check signs of an advanced liver disease, which exists before the gene therapy. But also we are involved in the management of the risk of short-term and long-term hepatotoxicity. Going into the practical point of view of selection of candidates, it is important for us excluding active viral and non-viral factors related to hepatocellular damage, cholestasis. Also is important ruling out an advanced chronic liver disease in terms of fibrosis or cirrhosis or liver dysfunction, and excluding focal liver lesions, particularly malignancy. But we have also another important aim, which is education of our patients, of our candidates, because we have to educate people to the potential short and long-term hepatological adverse events. We have to educate patients for the need of a tight monitoring program after infusion. And we have also to educate patients for the potential exposure to other hepatotoxic drugs or substances, among them alcohol, herbal products, and dietary supplements. So the selection of candidates have several aims that are here clustered in 3 groups. All these groups need a specific timeline and specific test. All of them are mainly focused on remarking the existence of an active hepatocellular damage in terms of impairment of liver enzymes, virus screening. So we have to rule out the presence of active hepatitis B or active hepatitis C infection, but we have also to take care to morphological changes of the potential candidates. This can be achieved by the first level of an ultrasound exploration performed by experts, because we need to be aware of the signs of an advanced chronic liver disease that we have to rule out, together with the liver stiffness measurement, and when necessary, also considering CT scan or magnetic resonance. But we have also the risk of short-term hepatotoxicity, which mainly consists in ALT elevation that occurs both in hemophilia A and hemophilia B gene therapy. To face with this risk, we have to monitor enzymes, liver enzymes, together also with the factor VIII expression and the creatine phosphokinase level. This has to be performed weekly for hemophilia A at the beginning and every 2 weeks for hemophilia B. And in case of ALT increase, we have to rule out non-treatment related causes, among them other virus, rhabdomyolysis, the exposure to hepatotoxic drug or substances. We have also to refer patients to a hepatologist dedicated to gene therapy and working with the hematologist on any hemophilia treaters, because we have to measure the severity of liver damage, the impact of this rise of transaminases on liver function, the need for further analysis, and why not in specific and selected cases we can also consider the opportunity of performing a liver biopsies. After that, we have to make the final decision on immunosuppression therapy to face with the ALT elevation. And the most recommended drug is prednisone. It is recommended because the experience from the trial has been based more for corticosteroids. This is the typical schedule, including 60 milligram of prednisone by the oral route for the first 2 weeks. And after that, if you can check a reduction of ALT, you can start with tapering the dose. This is a schedule that is not rigid because it was not standardized, but in merit with the liver problems related with gene therapy, my final recommendation to hemophilia treaters is persuading your hepatologist that the liver is important for the health and the safety of this important and innovative treatment. And I hope these slides are open to the discussion later with all of you. Thank you. This is the schedule, and thank you for your attention.
Thank you to Professor Peyvandi for introducing me. So gene therapy is an innovative treatment to cure genetic disorders. This innovation does not only promise to change lives, but also highlight the key role of nurses in ensuring its successful implementation. Nurses are often the frontline caregivers who bridge the gap between complex medical technologies and patient care. Their involvement is crucial in relation to different levels of activities that include both practical tasks, such as facilitating the therapy's administration and identifying and managing adverse events, and organizational aspects. These include organizing the setting, managing patients' expectations, and helping coordinate the gene therapy journey. The journey through gene therapy can be very emotional and demanding for patients and their families. Not only nurses provide clinical care, but also emotional support. Communication and trust are two fundamental aspects. In these regards, nurses should educate patients about gene therapy by informing them about its benefits, risks, and the procedures. And by establishing such relationships based on trust, nurses can facilitate patients' understanding and also help them navigate their feeling of anxiety. Gene therapy in hemophilia can be considered a journey with different phases, and nurses participate in each one of these. In the pre-administration phase, nurses confirm that baseline assessments meet the criteria for infusion and that the equipment needed for infusion is properly set up. Also, nurses check the therapy is stored, properly prepared, and stored appropriately, and they also make sure that the label on the therapy matches the ID of the patient. Nurses also have to know the exact dose of the patient based on his body weight to check that the dose received from the pharmacy is correct. In case of allergic patient, it is possible to administer a pre-medication such as steroids or antihistamine in line with the instruction of the hematologist. Before the administration, it is also important to consider that the patient is well informed about potential outcomes and side effects. Nurses managing the gene therapy must be aware of the treatment side effects and the potential infusion-related reaction and be prepared to manage them. So now I'm going to illustrate the key steps of the infusion process, as well as some crucial instruction to perform this in the best way. First of all, it is very important that during the administration, nurses adhere to product timelines as much as possible. To start, they should identify a suitable peripheral vein to infuse the suspension, and to proceed with the actual infusion, nurses will need an infusion catheter with an inline filter and a programmable syringe pump. At this point, nurses are going to put the inline filter between the intravenous line and the syringe pump. Please note that the inline filter must be replaced every 100 milliliters of suspension infused. They should start the infusion at a rate of 1 milliliter per minute. It is possible to increase the infusion rate by 1 milliliter per minute every 30 minutes until they reach a maximum rate of 4 milliliter per minute. The overall infusion time should last between 2 and 5 hours. During and after the administration, nurses monitor vital signs like temperature, blood pressure, and heart rate. If it's necessary, the infusion rate may be reduced or the infusion can be discontinued and restarted later. In case of an infusion reaction during administration, nurses ensure emergency medications are available and also coordinate transfer to the emergency department if needed. The monitoring activities that follow the infusion are organized in different time frames. As you can see from the slide, the activities that are performed in the follow-up phase are different across the short, medium, and long term. In short, the role of the nurse after the administration of the infusion is to focus on continuous monitoring, multidisciplinary collaboration, and patient education, in particular that the patient must understand the importance of the follow-up, and offering both physical and emotional support. This ensured not only the safety and effectiveness of the treatment, but also patients' long-term well-being. Thank you for your attention.
Thanks very much, Marica, for this point that not really extensively have been described, but I thought it would be very, very important, the role of the nurses and the importance that they could have not only during the day of infusion, which is substantial, but also before and after. And also, last but not least, is a part of lab. You have several types of products, long-acting, pegylated, not substituted therapy. And Cristina is actually an expert in the laboratory of hemostasis and thrombosis in Angelo Bianchi Bonomi Polyclinic of Milan to collaborate with us for the measurement and efficacy of gene therapy for all those patients that we have dosed. Cristina, we will be happy to see your slides.
Thank you, Flora, and good morning to everyone. And thank you for iStage for this opportunity. Several clinical trials have demonstrated variability in efficacy following therapy for hemophilia. And some patients show no clinical response to the therapy, and the durability of the therapeutic effects varies, with some patients maintaining the expression of clotting factor for more than 8 years, some other with declined effect sooner. To evaluate the efficacy, we can measure analyzed bleeding rate, endogenous factors expression and activity, and the amount of exogenous factor used. Several factors contribute to heterogeneous outcome in gene therapy, such as pre-existing neutralizing antibodies to viral vectors, the development of factor inhibitor, some coexisting condition, the liver health, the age of patient. In fact, younger patients may lose expression of this transgene due to cell turnover. It must point out that currently gene therapy can only be administered once. Patient cannot receive multiple doses. And patients with less optimal outcomes from gene therapy can return to prophylactic therapy. In this study on hemophilia A, 12% of patients return to prophylaxis at a median start time of 2.3 years after infusion. In hemophilia B trials, the number of patients returning to prophylaxis range from 4 to 13.3%. As said, the presence of antibodies against viral vectors is crucial for gene therapy outcomes. There is high prevalence of antibody against the capsid due to prior exposure to the wild-type adeno-associated virus, with possible COX reaction with the recombinant capsid used in gene therapy. The total antibodies can form immune complexes with the capsid, redirecting the gene therapy product into the endothelial cell system. Neutralizing antibodies, part of a total one, can bind to some epitopes in the capsid acid, preventing the entry into target cells and reducing the efficacy of transduction. Some neutralizing antibodies can inhibit the capsid processing or transfer of gene material into the nucleus of target cells. For evaluating the gene therapy efficacy, the laboratory can measure the expression of factor transgene by means of vector genome copy number, can measure the quantity of factor with immunological assay for antigen, the development of inhibitors by means of Bethesda assay, but the most frequent approach is the measurement of endogenous factor activity that is performed weekly during the first month of post-infusion. And the test used can be the one-stage assay or the chromogenic assay. Just to summarize, the one stage is a clotting test, evaluating the ability of the test plasma to correct the clotting time, namely APTT, of a deficient plasma depleted of factor 8 or factor 9. Several variables are associated to the one-stage assay, such as the deficient plasma that can be natural, chemically, or immunodepleted in case of factor VIII with or without Willebrand. Another variable is the APTT activator. The most used is silica or lactic acid. The phospholipid with the different origin and concentration, and the reference standard used for calibrating the assay. Also, the analyzer can have an optical or mechanical measurement. All these variables contribute to high interlaboratory variability. In the chromogenic assay, we have a first step, a clotting phase, leading to the production of factor 10A. The amount of factor 10A is proportional to concentration of the clotting factor we want to measure, factor 8 or factor 9, because all the other clotting factors are present in excess in the reagent mix. The second step is the chromogenic phase, where the amount of factor 10A is measured by means of a specific chromogenic substrate. Usually, the one stage and the chromogenic assays show same results, but each of the two tests have specific features, advantages, and limitations. For example, the one stage is recommended by the American FDA as reference method for the hypothesis assignment of factor VIII products, while in Europe is recommended the chromogenic assay. The one stage is simple and more widely used, but is sensitive to the presence of lupus anticoagulant and heparin, and shows high interlaboratory variability. On the contrary, the chromogenic is insensitive to LAC and shows lower interlaboratory variation, but is more expensive and less used. The laboratory monitoring after gene therapy, in particular, is a condition where the one stage and the chromogenic assays cannot be equally used. For gene therapy in hemophilia A, has been observed that the one stage gives 1.6 to twofold higher results than the chromogenic. And recent studies have explained this discrepancy, suggesting that in the one-stage protocol, there is an accelerated production of factor 10A and thrombin. The chromogenic assay is the assay used for the assessment of gene therapy efficacy in hemophilia A. Factor 9 Padua transgene is used by all recent trials for gene therapy in hemophilia B. Also, in this case, once the one-stage assay show 2 to 3-fold higher results than the chromogenic. In particular, the levels of factor 9 are higher when obtained with silica as activator. The discrepancy between one stage and chromogenic assay in this case probably reflects insufficient content of factor 10 in chromogenic kits to match the enhanced activity of Padua variant. The addition of factor 10 in chromogenic assay leads to results similar to the one stage. This issue does not influence factor A measurement in chromogenic assay. For laboratory monitoring after gene therapy in hemophilia B, the correct assay is the one stage. And I thank you for your attention.
Thank you, Cristina, and also for bringing a little bit of refreshment on one stage and chromogenic and what they want to say. And as a clinician, we might not really be very familiar with that. So based on what has been said in all this presentation, I think the key take-home message is, first of all, the construction of the model of hub and spoke, which is recommended for hemophilia treatment using gene therapy. However, still I think is very much depending to the region and to the country of how the centers are organized and how we need in the future to define the role and the responsibility, and the certification needs more work. We need to make very clear the interaction between hub and spoke and how this interaction could be as functional as possible. I think there is no doubt after all this presentation, the role of every specific specialty is extremely important, and the multidisciplinary care model is a key condition for success in pre and post-infusion time of gene therapy. Patients with hemophilia need to be fully informed, and that information is very important. The language that you are using and the type of the information. The information needs to be complete for both safety and efficacy, however, need to be understandable for patients. So package of information, education, and discussion about gene therapy should be provided not only by physicians, but also by nurses and also patients association. So the collaboration between these three groups is very important for a better understanding of patients on gene therapy. What about the safety? Vincenzo tried to explain the increase of ALT and what was the significance, however, is not yet clear for all of us, and how we are going to control and long term and eventually the integration and how that should be managed. So safety really is a very crucial point that needs to be explained. Increasing liver enzyme, again, needs further investigation, and also eventually the information that we are going to catch in the future by the liver biopsy, whether the ALT and the liver enzyme is increased in patients in future, and data collection is important. And again, there is no doubt we need to have more data. As you know, World Federation of Hemophilia organized a data collection on the gene therapy, and we hope in the future that we could have all data post-dosing together in order to understand better the efficacy and safety for a long term. Okay, now I think is a time for discussion and question. Please go ahead, feel comfortable to come up with your question. Thank you, Bernard, that you're following us. And in view of EFA, is it still indicated to use gene therapy in hemophilia? That's a very good question. And I think it's not only for EFA, to be honest. I think there are several other products that are coming to the market. There is EFA, there is emicizumab, there are biosimilars, and also Mymate. I think actually this is a very good time for stratification of the patient and understanding their need, and they do need to decide what to decide. Some of the patients, they are coming to our observation asking completely to get rid of any type of prophylaxis for as much as possible. And in that case, we are trying to explain all the pros and cons of the gene therapy, limitation, and also all the positive side of the gene therapy. And if they are still interested, they go ahead. So I would say, yes, there is a space. Of course, not 100% of the patient they want it, but there are few percent of the patient they want it. In Milan, we already dosed 3 cases with hemophilia A. The experience all over were very good, and I think still there are patients that they want it. Can you address how you manage the hemophilia B patient who has AAV levels more than 6, 7, 8? So actually, as you know, for patients that are having a very high titer that is reported in the information of the drug, they cannot be infused. However, patients with less that extremely high level that the target is very clear, they can be managed, and it seems to be no interaction between the drug. Vincenzo, I don't know if you want to add something on that question. I cannot hear you, Solly. You have to make your mic on.
Okay, can you hear me?
Yes, now yes.
Okay, of course, looking at the antibodies against the virus particles is extremely important. And I suppose that in the next future, and I ask you also a comment on that, Flora, by the hematological point of view, I think that possibly we can change our attitude depending on the level of the antibodies we can detect to make the final decision of addressing or not the patient to the gene therapy.
You know, right now for hemophilia B, to be very honest, a part of one single patient who did not respond, the rest of them, even with the presence of antibody, there was no interaction and no correlation between the response and amount of antibody. So that's the reason I think for hemophilia B, what we are doing right now is just patient, they can use it, we titrate it, and we see if the level is extremely high, as I said, but otherwise they can go through. For hemophilia A, those that have anti-AAV antibodies, they cannot go through. So for patient on extended half-life prophylaxis, another question with factor 9, how long would you continue prophylaxis? I think the question is when you are dosing with gene therapy, we are waiting, and usually after 4 to 5 weeks, at least for hemophilia A, because for hemophilia B, we did not have any patient. I don't know exactly the timeline, but in our hand for hemophilia A, it was 4 to 5 weeks, and we start to have some expression. And at that time, I would say the level of extended half-life product is already abolished, of course, and the patient continue the prophylaxis until the level of expression is over 5 to 10%. Another question, measuring factor 9 level while on prophylaxis complicates assessment of transgene expression. Here, I'm going to ask Cristina. Cristina, if we have patients actually that they are on factor 9 and you were showing that we need to have one stage for the transgene expression, how are we going to do it?
Personally, I know I have no experience with hemophilia B gene therapy. I think also for hemophilia A is not simple to understand the production, when start the production of endogenous transgene. But I think for factor 9 is more difficult. I think when you obtain results very higher than you expect
I think the treatment.
Yeah, I think this is the point to consider because for factor PAD1 transgene, we have very high results than expected with
so the differential levels of factor 9 expression, to your opinion, is a good target for understanding that.
Yeah.
And also the timeline, because if you're using extended half-life product, so the expression is remaining a maximum for 2 or 3 weeks. If after a month you still have the expression without the infusion, definitely that expression could not be due to the extended half-life products. So the other question is, may you, let me see, because I'm just reading. How long is too long to be on a steroid before considering alternative steroid sparing to avoid toxicity? Good point. Vincenzo, do you have any answer for that?
It's absolutely complicated giving you the right reply to this question. But anyway, you could wait for 3 weeks, 4 weeks, just to look at the transaminases go down or at least stop to increase. This is a good point for you to start the tapering of steroid. The problem is if you have after this time point a further increase of steroid. I think that if you want a specific answer to this question, I'm so sorry to say that, but we need the liver biopsy because we have to justify the use of immunosuppression by any more specific evidence on the mechanism behind this rise of transaminases. So in my case, I would propose to the patient to perform a liver biopsy and after that, deciding what to do.
Actually, one of the questions, Vincenzo, was for liver biopsy. When is the time to make the liver biopsy?
But actually, this is another tricky question. But anyway, we have to try to put order because the trials didn't cover exactly these aspects. So now we have to always associate to the increase of transaminases the measurement of the severity of this increase on liver function. If you don't have liver dysfunction, you can wait and see. But if after several weeks you have still a rise of transaminases or you start having a little impairment also of liver dysfunction, that means the reduction of the synthetic function of the liver, you have to consider liver biopsy before starting a stronger treatment with the higher doses of corticosteroid or the addition of other immunosuppressants.
Thank you, Vincenzo. And there is another question in terms of whether emicizumab is better than gene therapy, which is the best choice. As I said before, there is no best choice. The choice is very personal, and what is important and what is happening in my center, which is a hub center with a large number of hemophilia patients, I really can see that choices are very, very different from patient to patient. Depends on what is the need, what is the facility for your patient, for the venous access, the type of the protection, the amount of the activity, the age of the patient, the risk of thrombosis. I think there are several aspects that you have to consider before to propose, the drug to your patient and together with your patient, because I think this is very important that persons with hemophilia, they have to understand and choose together with their physician what is the best for them. There is a question, Vincenzo, in terms of the cells. So now liver, we are using liver to target actually the expression. Would it be more convenient in the future to think about endothelial cells to be the target for the expression?
I think it's a good point, and we have to explore the technique to achieve the expression of the transgene in endothelial cell. But just because it is the physiological way, so I would expect more reliable data in terms of safety by considering this target.
Thank you. I want to go to Cristina. Cristina, I think people needs to have clear-cut information. If I have a patient with the extended half-life factor 8, and I'm using the gene therapy for hemophilia A, what type of assay I need to use for understanding the efficacy of infusion of the drug and the efficacy of endogenous expression of factor VIII. For example, I have a patient on Elocta and I'm making a gene therapy. So what was the assay that you were using before and what is the assay you're using after dosing?
Okay. For Elocta, in our laboratory, we can use equally the one stage and the chromogenic assay gave the same results. In fact, during therapy, after gene therapy, we start using both tests for monitoring the therapy. And when the endogenous factor VIII start to be produced, we start to see a different behavior of the two tests. We start to see one stage assay higher than the chromogenic assay. And in this moment, we understand that factor VIII is starting to be expressed, to be produced.
What about if the patient was on Hemlibra? What type of the assay you are using?
Okay, if the patient is on Hemlibra, we must use chromogenic assay with bovine reagents because this kind of assay is insensitive to Hemlibra. We have a patient in this condition, and the first 2-3 weeks measuring factor VIII, we have factor VIII less than 1%, and that is his level of basic factor VIII. And after the 3rd, 4th week, we start to obtain results higher than the 1%. And we are sure that what are measuring in this moment is the factor VIII the patient are producing, start producing.
Thank you very much. Marica, since we have 1 minute, what do you want to leave as a message to the nurses that are working in Hemophilia Treatment Center and they all want to be interested to be as a participant of the multidisciplinary team for the gene therapy in future?
Yeah, I want to say that education is fundamental for nurses. In this way, we can participate in a multidisciplinary team without difficult. So education is very, very fundamental about gene therapy, about the procedures. So this for my colleagues.
Thank you. I want to thank all the speakers for a really very good informative session on the gene therapy, and thanks ISTH and France Foundation for helping us to prepare it. And please, and thank you for participation. And please don't forget about the evaluation of the form if you are interested to have the CME. Have a good evening and hope to see you soon. Bye.